welcome to all of the attendees. It's so good to have everybody here for this CE event. Just a couple of housekeeping items before we officially get started. This will be a roughly 40-minute presentation with time at the end for questions and answers and hopefully some dialogue as well, because we always like dialogue. Please note that CE credits will only be available to live attendees, not for people who view the recording after the fact. And please drop questions into either the chat or the Q&A as the presentation is happening, so that we can absolutely get to them at the end. We love to have an active chat going on during this presentation. It makes the end much more fun, I think. So with that said, today we are here with Dr. Maurrasse from McLean Hospital for a discussion about self-harm in adolescents and young adults. Dr. Maurrasse is a medical director at 3 East DBT Browning Medical Intensive and Step-Down Program at McLean Hospital. As medical director, Dr. Maurrasse provides child and adolescent clients a continuum of care through DBT, dialectical behavioral therapy. Her longstanding interest and experience in skills-based and behavioral interventions has made her an expert in this field of adolescent mental health. And we are so honored to have her here today and to be doing this really important CE event and presentation. So, without further ado, I will turn over this presentation to Dr. Maurrasse.
Great. Thank you so much, Dr. Fiak. It's so great to have everyone joining us. And first and foremost, I'd just like to go over the idea of self-injury. What we will be discussing today will be less tied to specific diagnoses and much more centered on the actual behavior. So we're not going to base our interventions on, say, if self-injury is happening in the context of bipolar disorder versus major depressive disorder versus anxiety disorder. What we're looking at is really getting curious with the patients around their understanding of the behavior and how we can intervene. So I am also a DBT therapist, which means that we will be looking at this assessment and addressing it in treatment through that frame of really looking at the behavior and helping patients understand it and really get committed to changing the way in which they respond. So with that said, when we're talking about self-injurious behaviors, we are looking at non-suicidal self-injury. So the intentional harm to self that is not meant to end someone's life, but does result in some sort of tissue damage, right? And the self-injurious behaviors cover a range of behaviors, including punching, hitting the self, cutting, burning. It may involve using implements or just using your nails or whatever is available to the individual at the time. So I do have some slides. We can start with that in a few minutes. So with that being said, I'd love to welcome your questions, but also your curiosity in thinking about your initial response when you think about a patient with self-injury, your questions and thoughts, how for some people that may be really disconcerting if they have a patient who starts to engage in the behavior, or if the patient has no history of it, has been able to resolve it and then starts over again. So in this presentation, I invite you to be curious about how to do the initial assessment at the start of therapy, and then follow up with how to deal with it as it happens once you've established a baseline with that patient and you've had some agreement about how it will be dealt with in treatment. So let's, are we sharing the slides? Oh, we already have a question.
I am pulling them right up. Give me one second.
Oh, excellent. Okay, excellent. So while you're pulling it up, I'm just going to address one question who said, someone said, are self-harm and self-injury the same thing? For the purposes of this conversation, they are. We will be using them interchangeably. And another question was, can you use alcohol to self-injure? That is an interesting question. So if the intention is to cause more harm, I guess there is one context where you can see that as intentional self-harm. And we do know that using substances, unfortunately, can worsen scenario. And we'll talk more about that. So can we go to the next slide? Okay, so as I said, we will assess the self-injurious behaviors. We'll look at how it's dealt with in treatment. And then Dr. Fiac and I will go over a case study together, and we'll go over some reflections and questions. Next slide, please. Next slide. So first things first, when we're looking at self-injury, it's really important to get a good detailed history. We will look at the history together. We'll look at the function. We'll also map out what I like to think of as vulnerabilities, right? What are the factors that make it more likely for someone to experience the kinds of urges that will lead to the behavior, and hence the behavior down the road? That could be anything from being more fatigued, having some emotional crisis, having some interpersonal difficulties with peers or with parents, failing a class, getting kicked off a team, whatever incident that makes it more likely for the patient to have a hard time coping, we will look at together. We want to do all of this by establishing a baseline of what I like to think of as non-judgmental curiosity. So we are not encouraging the behavior, but we're also not criticizing the behavior. We're looking at it as just that behavior that is meant for us to understand how the patient is finding it to be helpful, right? What is it about this particular action that they keep going back to over and over again to get some sort of relief, potentially? We'll also look at commitment. I think it's hard to consider addressing and assessing self-injury without considering commitment in the context of helping the patient decide, does this make sense to assess it? And furthermore, does it make sense to consider refraining from the behavior? All of that foundation helps us deal with it in therapy, so that if the patient's committed and we've addressed it and we have obtained all of this history and the behavior happens, we can look back and say, wait a second, what were the vulnerabilities as we understand them that got in the way of us reacting differently or using a skill in response? And we can also see if we've missed anything in our initial assessment and return and make adjustments as needed. So this is done in partnership with the patient. This is not something that we take on and are committed to as clinicians on our own. It's really with the understanding of the patient and the patient's own desire to enlist the help of the therapist in addressing this behavior. Next slide. So in terms of the history, I usually focus initially on the onset, right? How old was the patient when they initially started engaging in the behavior? How frequently do they engage in the behavior? What type of injury do they engage in? Like I said, there's a wide range, including hitting, punching, cutting. Patients may use razors, scissors, or they may not use any implements at all, or sometimes they can get very attached to using a specific means, right? It's also important to look at the location of the body, whether they're injuring. This could be anywhere on the face, arms, lower limbs. It really depends on the patient. The other thing to consider too is the time of day. This is important for school age patients because at the end of the day, if there's less structure, they might be more vulnerable to engaging behaviors that they may have been putting off throughout the day, or they may have been dealing with urges by using some distraction through the structure. We look at the mood. Also, we look at the consequences. How did people respond when they found out about self-injury? Were they inadvertently reinforcing the behavior, meaning that they react in a way that made it more likely for the patient to engage in this behavior? Or Did they reduce their frequency? Lastly, it's important to consider, how does the patient experience themselves before and after the behavior? What emotion was predominantly there before they engaged in self-injury, and after they did, how did they feel? It's not uncommon for patients to notice feeling really intense emotion before the engaging in self-injury, and right after engaging in the behavior, they might have some experience of relief potentially, followed by some shame or sadness even at having yet again engaged in a behavior that they themselves have some criticism about. The most important thing that I want to bring your attention to is actually the function of the behavior. So remember, I said we're not focusing on specific diagnoses, right? We want to understand, how does this behavior help our patient cope, right? They're ostensibly using something that we see as problematic, that they see as a potential solution to dealing with difficulty in their life, right? So it's not uncommon for them to use this as a way of modulating intense emotion. So if anger shows up or intense sadness shows up, self-injury may be a form of reducing that intensity. Conversely, it's not uncommon for patients to, if they're feeling quite empty or numb, use self-injury as a way to feel something, anything, even if it's a painful stimulus. Patients may sometimes use it as a punishment if they feel they've crossed a value, and they use the self-injury to punish themselves. Validation may be another way of using self-injury, as well as a way of not entertaining suicidal ideation. Even though we're talking about injury that is not meant to end someone's life, there's still a connection. We know that people who engage in self-injury, unfortunately, are at higher risk of making suicide attempts later on. We also know that some patients, when they're experiencing suicidal ideation, sometimes use the self-injury as a way of reducing the distress in their mind so that they don't experience higher urges to attempt suicide. Lastly, it's not uncommon, and again, these functions are not exhaustive lists. This is just an example of potential functions. So I encourage you to be very curious when you ask the patient, what is the function of this behavior? How is this helping you cope in the moment? There is something called symptom substitution, where sometimes patients engage in a wide variety of behaviors, not limited to self-injury, substance use, restrictive eating. And when they don't have access to other behaviors, self-injury may seem much more prominent when it's really part of a host of various behaviors that are used for distress tolerance. And as I said before, there is looking at vulnerabilities and triggers, right? So these are very specific to the patients, and you can get information about this by looking at a timeline of one instance. So I would recommend asking the patient about one specific instance of self-injury and having them walk you through, from the start of the day, how did they arrive at the behavior, right? What were factors including their sleep issues, difficulty with eating, difficulty maybe making it on time to a job or to school, all the little links along the way before the behavior actually occurred. And you will build on this over and over again by gathering more data so that you are joining with the patient in being curious about this rather than being critical about it or encouraging it. And this is important, differentiating between behavior that we think of as respondent versus operant. Respondent in the sense that, are they noticing urges to act on the behavior when they see an implement, when they see a cue in the environment that prompts these urges, versus much more operant, as we think of as operant conditioning, when they have had the experience of self-injuring and noticing a reinforcer, meaning do they notice relief after self-injuring, and that reinforces the behavior because after committing the act, there's a consequence that either increases the likelihood of the behavior or decreases the likelihood of the behavior. And in repetitive self-injury, they might be experiencing a reinforcer that's increasing the likelihood of the behavior. And in some patients, that may just be relief at not having to experience the emotional intensity that preceded the self-injury. And lastly, I want us to think about the commitment piece, right? whose goal is it anyway to reduce self-injury? And can the patient see the wisdom in giving up the behavior? So honestly, none of this matters if we're not on the same page as the patient in recognizing the wisdom in even having this assessment, right? So if you've been able to get curious with the patient, they can then tell you in their own words, why does it make sense for them to use this behavior? And hopefully why it doesn't make sense to consider giving up the behavior, right? That commitment can make monitoring and addressing this behavior a lot easier because we don't want to rely on body checks or having to fact check our patients since we're working in alliance with them. We're working as a team to make sure that we are getting the data we need to reduce the likelihood of the behavior. Next slide, please. Next slide. So as I said, in terms of the monitoring piece, we rely quite a bit on self-report. So in DBT, we use a diary card where throughout the day, they're reporting not just on the urges for self-injury or the behaviors, but they're also reporting their use of skills. They're reporting fluctuations in their moods and various states. These are all points of data that allow us to figure out if the behavior occurs, what were the other factors that contributed? What was present during that time so that the patient can have an opportunity to reflect on the data they've gathered and work on a solution with you. And this behavior analysis and the chain analysis can help us gain more links in the chain because it's not uncommon for patients to sometimes describe their self-injurious behaviors or other maladaptive behaviors as impulsive, when in fact there are many, many intervening or middle steps that happen between the time they had the thought and the time that they engage in the behaviors. So all of this is meant to not just gather information, but to actually slow things down enough so that patients can themselves begin to intervene a lot earlier in the chain before they engage in the behavior. Observation can also be helpful. You may notice yourself that, oh, there's a new scar and ask the patient about it. But again, we don't recommend doing body checks because we're relying on the patient to gather this information and do the self-report. We often tell our patients that we're not great at detecting lying. It is not our job to detect lying because we are engaging in a relationship with the patient that's centered on their commitment to do this work with us and their commitment to ask for help when it is needed. With all this data gathering and use of skills that are much more effective, we sometimes use something called cope ahead, which would help the patient decide, given all the information they have, when they're potentially going to a situation that increases the likelihood of distress, what can they do at various points to reduce the distress? And they actually map this out before going into that situation. I would like to say that when it happens in treatment, so let's say you've gathered all this information, you've established with the patient what makes them much more vulnerable, what gets in the way. When it happens, we have to be really careful not to lean in a way that reinforces the behavior. And here's what I mean. It shouldn't lead to more talking in a way that patient feels like, oh, I get to spend more time with my therapist. I get to spend more time with this person who's very warm and understanding after I've self-injured. There is usually an understanding even before you reach that point that when self-injury occurs, there's a 24-hour wait period before they can engage with you. This gives them an opportunity to work on one of those self-reports, including a chain analysis where they can take some time and reflect and figure out what happened this time, what was missing, and then they can come back in therapy and share the data that they've gathered upon reflection. So it's addressing it without reinforcing that's really key so that we're not losing an opportunity to gain information, but also not lean in with the kind of warmth that undermines the seriousness of the behavior. Next slide. So with that, I'd like to pause for a second and then have Dr. Fiak touch lean in with the case study that we're going to discuss.
Hi, thank you so much. Thanks for all that background information. I think that approaching these complex clinical presentations in a non-judgmental manner and with curiosity is so important. And remembering that these symptoms serve a purpose. If they didn't, people wouldn't need to rely on them, and they serve a really powerful purpose. And I know it can be scary, especially scary for family members or for friends or loved ones who don't understand the very nuanced difference between self-injurious behavior, self-harming, and a suicide attempt or suicide ideation even. And I think it's super important for everybody in the system to be educated and to gather as much information and understanding as is possible, so as not to inadvertently almost reinforce the symptoms. With that said, I think we've all worked at different points in time when we've worked with adolescents and young adults. We've been presented with clients who have self-harmed in some type of capacity. And oftentimes the presentations have an added layer of complexity because there are multiple diagnoses going on at the same time. And it's really hard to suss out, what's really happening here. And even in the chat, I've seen some questions around what's OCD and what's self-harming behavior, is IV drug use self-harming behavior? Is substance use self-harming behavior? And oftentimes, a lot of clients present with very real diagnoses of addiction, while also self-harming or an eating disorder or trauma, et cetera, and really understanding what's going on from a diagnostic perspective. So one case example that I wanted to present was of a young woman who at the start of treatment was 20 years old, and she was in treatment for quite some time, even prior to coming to us, and was in treatment with us over the course of almost 3 years. Historically, she had been in both individual therapy. She had been on numerous different medications, probably had been in therapy since the age of 5 or 6 years old, struggled growing up with sort of like just intense emotional states, and a very invalidating environment. I think that she would report that she was often made to feel like her emotions were unwarranted, that she was dramatic, that she was embarrassing to the family, that she was overly sensitive. These were sort of words that were used to describe her by her parents, and also by her siblings as well. Everybody else in the family was more quote unquote buttoned up tight. She came to us primarily to get treatment for an eating disorder, and really didn't disclose any self-injurious behavior upon admissions. And when speaking to prior treatment people who she had had treatment with before, there was never any indication of it. So we really went into treatment exploring her relationship with food. And she was an individual who would restrict a lot during the day, and then in the evening would binge. And she would not purge. She would binge, and then the next day restrict, exercise to compensate, and so on and so forth. The cycle repeated itself. And what came out during treatment with her was that after binges, she felt such a tremendous amount of shame and guilt for being caught in this cycle and not being able to control the cycle, that she would self-harm. And it wasn't probably until about 6 months into the treatment, I think, until really a relationship had been established where there was trust, where she didn't feel like she was being judged, where she felt like she was being approached with true compassion and curiosity, that she was able to say, you know, in addition to this that's happening at night, I'm also doing this. And please don't tell my parents, like, they will send me away forever. They're going to think that I'm suicidal. They're going to put me in a hospital. So on and so forth. So the treatment really consisted, actually, let me pause there for a second before I get into what the treatment, I think it's really important to sort of explore the problem, or the presenting problem, the presenting diagnoses, and allow people to ask questions in the chat just about anything that they would have questions about for the client. What more information would you want to know? Dr. Maurrasse, I don't know if you want to ask some more questions. Well, make this more interactive.
And it's in the case that you just presented, it's so familiar, in that it makes sense that this person would have been exposed to so many different medications. It's not uncommon for our patients to go through multiple trial medications, which makes the assessment so incredibly necessary, right? There are no specific regimen or combinations of medications to address self-injury. There's much more evidence-based for behavioral interventions like DBT in helping patients deal with this. So it's not uncommon to use medications to maybe decrease the intensity of some of the emotional distress. However, the mainstay of treatment is the behavioral interventions.
Correct. And diagnoses that were thrown out or thrown into the mix historically as a kid, ADHD, to explain like this emotional reactivity and sort of impulsivity. And then as she got older, bipolar disorder. I see a question, and a trauma survivor. No, she did not. I mean, I think it's a difficult question to answer because I think trauma falls on the spectrum. I think living in her house did feel very invalidating and traumatic at times. In terms of, was there physical abuse, sexual abuse? No, but I think that there was a lot of emotional trauma that was occurring in her house growing up. Besides age, sociocultural background, please. Yes, she is a Caucasian female who grew up in a very privileged home, high expectations in terms of education, was in a private school that felt to her very pressured, both academically and just socially too, like how she felt like she had to dress and act and look a certain way. Just watching more questions coming in. How do you, so this client was over the age of 18. And still living at home with her family. And it's a balancing act, right? Because on this, her immediate reaction was, don't tell my parents, don't tell my parents cannot know. And what we know is that unless we also provide some type of treatment to the entire system and do work with the family, the chances of her being able to heal in that home become much less likely. So of course, on the first day that she discloses that she has been self-harming following binges at night, that was not going to be the day that I certainly pushed to involve her parents. But again, I think the relationship and the power of a therapeutic alliance is second to none in terms of treatment interventions, and in terms of looking at whether treatment is going to be successful or not. And over the course of time, I think the trust in the relationship allowed her to be open to the fact that bringing her parents in was to help her, because they needed to get help. They needed to make changes. They needed to do their own skills-based work as well. They needed to understand this new language that we were teaching her around DBT skills work, because she did love her parents, and she wanted to, she needed to stay in that home, I should say. I don't think she actually wanted to, but for where she was at that point in time, it was where she was living. So we were able to bring the parents in so that they could have access to work too. But I just want to be clear that with the parent coaching, if it's an hour long, maybe like 3 minutes is spent just saying, yeah, so-and-so is doing great this week. They're working on these skills. And then 57 minutes is spent talking about the skills that they need to be working on and what they need to be doing. Because oftentimes parents will try to flip it, not understanding that, that hour is really meant to be working on themselves, just like their child is taking a lot of time and doing a lot of hard work on themselves as well.
I will add too about the disclosure piece that paradoxically, sometimes our patients on the one hand are performing really well academically and in socially, and then they're secretly self-injuring, right? And they're having the repeated experience of invalidation where the parents are responding to one set of data in terms of how the patient's presenting without knowing about the self-injury. So the patient has this experience of having a lot of distress that they're experiencing internally, and that they're not getting validation or recognition in terms of like what's happening. So the self-injury helps to externalize it in a way, while them keeping it a secret prevents them from actually getting the help that they need.
Mm-hmm.
In helping them see the wisdom in disclosing it, it may reduce some of the isolation, and it may actually help the parents validate the kid a lot better, because then there's a lot more accurate expression. There's a lot more data for the parents to respond to in terms of understanding the kid's full experience. So while there's a lot of reticence on the kid's part because of all the shame and the concerns there, it's actually an opportunity to give the parents a chance to more effectively respond in a way that could be helpful for the patient.
Mm-hmm. So in terms of treatment with her, when we can we actually pull up the slides? I'd love to go to the slide where Dr. Maurrasse, you sort of summarized sort of the purpose of the self-injurious behavior, the precipitating factors. Elizabeth, do you mind pulling those slides back up? Because I think that would be a really cool way to actually go through this case study. What was difficult and complicated with this young woman is that what we know is that, on the surface, like what typically immediately preceded the self-injurious behavior was a binge. So we also had to look at the eating disorder as well. Under the surface, the binge, the self-injurious behavior were rooted in like the same underlying sort of triggers and vulnerability, but we did need to, have her start meeting with a dietitian. If you don't eat all day, you are going to set yourself up for a binge at night. And when you binge at night and then start feeling that shame and guilt, so on and so forth. So there was some very concrete work that we had to do around psychoeducation with the food, getting the client set up with a dietitian and following a meal plan. She was restricting all day. There was a lot of issues around control and wanting to feel in control in some type of way when her emotions sort of felt so out of control. And she's been told all of her life that she's dramatic and emotional and out of control of her emotions and impulsive and this and that. So when we look at the history, while she had never disclosed what was going on, the behavior had actually been taking place since high school. She reported probably since around her sophomore year in high school. And she had been keeping that secret, for so long. She had gotten through a lot of college and without disclosing it to anybody. And it was really serving such a powerful function for her. As I said, we know the events and the time of day, etc. In terms of function, I think definitely modulating intense emotion. Also, as she would say, she would feel so angry at herself for binging after doing so well and being so in control all day, that there was an aspect of it of wanting to like punish herself as well. So that was something that certainly stood out to her. She was not entertaining suicide. She said she was not suicidal at all. So that did not play into her presentation. She was committed to therapy. She was committed to the process. Once she actually disclosed what was happening, she was she did not want to feel the way that she felt anymore. She just would always say, I am so tired. I am so exhausted of feeling this way. I just want to be happy, and I want to be, quote unquote, like, I want to be normal. I want to have a normal life. So she was very committed to the work that we were doing. What was good was that in terms of dealing with sort of the root causes and the underlying issues that were contributing to both the way that she utilized food and the way that she utilized self-harm, was through doing DBT therapy, both individually and in groups, and going through different skills around emotion regulation, around distress tolerance, around interpersonal effectiveness, especially when it came to communicating with her family, what her needs were, how she was feeling, how it felt when she when they used some of the language that they used with her. And also utilizing, she got very, very, very into both meditation and Reiki was really powerful for her as well. And getting in touch with how of staying in the moment, and really getting in touch with where she was in the moment and allowing moments to pass. Learning how to ride certain waves, learning how to take opposite action. Those were some of the skills that, just for her in particular, worked very well. I want to pause here and see if we have any more questions, comments. I see comments around, please address the typical parental response of punishing the behavior. Yeah. Do you want to?
Yeah, I think we probably could spend like a good chunk of time on that. I'll say this is where I think what you said earlier around the spending time to do the education is really important of the parents. I want us to think about what it would feel like to see somebody we really care about causing harm to themselves. It's really challenging to sit with. And as a parent, it would be really awful to imagine your child, causing themselves so much physical pain. And I've seen a wide variety of response, everything from helplessness, hopelessness, to anger, all attempts to figure out how they can fix this behavior, either trying to be understanding, validating, or downright punishing, as someone said. So this is where the education of parents happens, by explaining to them that it is a means that the patient has found to help them cope right? Like what we're seeing as the problem, even if the client sees it as a problem, they're also seeing it as, in effect, a solution that brings about some relief. It's brief, but it's significant enough that they keep going back to it. We don't repeat behaviors that don't bring us something, right? And that something for that patient could be relief, distraction, something that changes their level of pain to a level that's much more manageable. So we really try to get parents to understand that idea that the child is doing the best they can under their circumstances, and our role is to help them find a way to do better.
Right.
If punishment worked, then they wouldn't have looked for us, right? They wouldn't have come to us for consultation. It doesn't work because it may be preventing the child from doing something without giving them a means of coping with the difficulty they're having in the first place. So part of the history gathering I meant to say earlier is figure out with the patient, has there been a point in time where you didn't self-injure? So were you able to go 6 weeks or 6 months or even 6 days? And the reason that question is important is to figure out what are the strengths that can help, that we can build on, but also figure out what was that period of time where they were refraining, were they in effect what we call white knuckling, right? Were they sort of not using that behavior, but actually not dealing effectively, right? So it's not uncommon if kids don't have skills, they may be refraining for a brief period of time, and then eventually they return to the behavior because they haven't found a way to deal with whatever it is that they were dealing with in the first place. So when parents use punishment, they may succeed for a short period of time in getting the kid or a young adult to not engage in a behavior, but they haven't necessarily made progress in helping that child acquire a set of skills to not be tempted again in using the behavior or using some other behavior to deal with that distress.
Yeah, I also think it's like super important, as you said, you know, imagine how it feels to be a parent or to love somebody and watch them, you know, harming themselves in that way. So parents are scared, and also themselves often questioning, what did I do wrong? I'm bad, and feeling a tremendous, there's almost a parallel process where they're both the client and the parent is feeling a tremendous amount of shame and guilt and self-loathing. And for myself, I'll speak for myself as a clinician, in working with parents, it helps me to remember that too, and have compassion. I know that the client is the one that, you know, the identified patient, the person that's coming to us seeking treatment, and the whole system is in pain. The whole system is suffering as well. And I think when parents can understand that pain that they're feeling is similar to the pain that their child is feeling, it also helps to increase their own sense of empathy, understanding, and hopefully helps them to move closer towards validation versus judgment.
Right. And another thing I'd like to say too, not entirely related, is that it's not uncommon sometimes for parents when in that punishing mode. I've heard parents say, you know, my kid is manipulative or manipulating me, right? That really speaks to assigning some intention to the behavior that may or may not be there, right? So one of the ways we can quickly get really angry or judgmental is when we start imagining that we know what's in the child's head, when we, if in effect, don't. So when parents get in that punishing mode, I would recommend definitely taking a few steps back with them, reminding them that we don't know why the kid is doing this, and our goal is to figure out the function with them non-judgmentally and give them a better approach when they're in distress.
There's a really good question that came in here that says, how can parents be accepting of their child and yet not reinforce the behavior? And that's where I think it's really important to like differentiate between the behavior and the person / the emotion that they're experiencing. And we always want to validate them as an individual and the emotions that they're experiencing. their emotions are valid, and that their emotions are valid, period, like full stop. And as a parent, I love you. I hear you saying that you're feeling X, Y, and Z. And I'm here to help support you in working through those feelings without using X behavior. And we're in this together, and this is what we're going to do. So you're not validating the behavior. They're in treatment because we want the behavior to change. The behavior is harmful, and it's dangerous. It's serving a purpose. But the purpose of treatment is to find a different behavior, different ways of coping with the emotions, which are very valid. So it's nuanced, and that's the dialectic too. And that's part of teaching the parents the language around the dialectics.
Absolutely. I think there's a very real fear that accepting reality as it is means that we're condoning it. Validating means that we're agreeing, when those two things are not true. That there is a way for parents to accept the reality that their kid is struggling, and that does not necessarily mean that they're reinforcing it. So there's this fear, there's this wish that, okay, if I don't accept, if I don't validate, then things will change. When we know that when people feel seen, it actually helps them engage with you. It helps them start to begin the change process. But that can only happen if we're on the same page and accepting the reality that is. So accepting and validating the patient doesn't reinforce the behavior at the outset.
There was also another good question. Can staying in the moment backfire and increase the felt dysregulation?
That's interesting. It's one of those questions where I want to immediately say it depends, because we would need more information, right? We know that sometimes staying in the moment allows people to get more information that actually slows down the process and makes it less likely for you to get dysregulated. When you think about how quickly we get dysregulated, we walk into a situation, we see a behavior, and we start making a bunch of assumptions that can really quickly lead to the dysregulation. However, staying in the moment and slowing down makes it less likely to happen. And I wouldn't recommend trying to do mindfulness practice in the midst of being highly dysregulated. I would actually recommend first something like doing an ice dive, something that really immediately brings down the intensity before even practicing staying in the moment, right? Something to calm the system down before we go in that direction. So it's as if you're panicking, you're having a really hard time, and I say to you, stay in the moment, stay present. I don't think that would be very effective.
Right. Sorry, there's so many that are coming in, and when the screen changes, I lose the ones, so I'm going a little bit out of order. What are some suggestions for effectively addressing a patient who is actively self-harming on an inpatient unit with interdisciplinary team?
Yeah, this is a parallel to what you're saying in terms of helping the whole system. In that case, it's helping the whole team. And just like we talked about gathering data around the patient, doing a chain with the patient, I would actually recommend doing the same thing with the team, right? Figure out what the team's vulnerabilities are, figure out what the team's actually doing that may be inadvertently reinforcing the behavior, making sure the entire team's on the same page as to how they're going to respond, right? So if you have one member of the team, when the patient self-injures, the member sits with the patient, spends some time with the patient, helping the patient calm down after maybe addressing the wound, and then spend even more time with the patient. And you have another team member that's a lot more brief. The approach is really different, and the first team member may be inadvertently reinforcing the behavior as the patient learns, like, I can get more time with this person. I get to skip groups that day. I get to be pulled out of classes that day. There has to be an agreement from the team as a whole. Will we still make the patient accountable throughout the day in terms of like attending their group therapy session? Will they still have their individual sessions? Will they still have their visits? Will they have certain privileges perhaps pulled? Is there something they can work towards if they go this many days without the self-injury. So there has to be some agreed upon way. And this is after carefully assessing the behavior, just like we would do with the individual, but assessing it also in terms of like how the unit is responding and how the unit understands their relationship to the patient, their relationship to the behavior, and how they're maybe inadvertently contributing to maintaining this behavior.
In regards to treatment, would you ask them to get rid of sharps / self-harming tools? And I'll add another one onto that, especially with the younger age group. What would the expectation be of parents in the home around sharps, other, tools that could be used for self-injury?
So this is a unfortunate balancing act, because on the one hand, my first response would be to reduce the accessibility of these things, and it has to be done with the patient. So again, it's a team, right? So we're not just removing these things, we're doing this in consultation with the patient expressing understanding. How is this helping me reach this goal of not engaging in behavior? Conversely, if you're finding that you're not just removing the sharps, but you're attempting to convert your home into a residential or inpatient setting, then there has to be some discussion around, is being an outpatient the right level of care for that child or that young adult, right? There's a removal that's done in partnership with the patient as a way of that they can work back up to having access to these things, but it cannot be to recreate a hospital setting at home.
Yeah, I was going to say the same exact thing, because it can get taken to such an extreme where, a sibling's stapler in their desk, and it's at a certain point we have to assess, is this the right level of care given where the patient's at this moment in time, basically. Let's try to get through one or two more. How do you manage parents that want to do body checks to see if self-harm is continuing to happen?
Yeah, it's a bit of what we were addressing earlier in terms of validating. I would first and foremost validate the parent's concern. Again, it's terrifying to know that you have a child that's self-injuring, especially one that's living in your home. And it can be very tempting to want to take control of the situation and say, I will monitor this, right? But I want you to think about what that means, right? Like, are you taking a 15, 16, 17-year-old and having them expose themselves to show you the scars that are present or not present, versus doing this in the setting of a relationship where the child has a commitment with their therapist, preferably, around refraining from the behavior, and the kid can then self-disclose to the parents and to the therapist. I don't recommend doing body checks. It's terrifying, and my worry with that sort of behavior is that it's more based in fear than based on the kid's commitment to not self-injure. You may get them to maybe white knuckle their way through not engaging in behavior for some time, and they may potentially start doing it in places that you can't potentially check on, or engage in other behaviors to address their distress.
Right.
So you can validate their concern.
Right. And if that's the only way that they are experiencing their parent giving them attention, then it actually could become paradoxically reinforcing, versus rather than doing the body check every day, at the end of the day, make sure that you have 30 minutes where you're sitting in a room with your child, asking them what the best part of their day was, if they laughed today, what was what's something that you're proud of, from just having validating, curious conversations with them. I'm just looking at my clock. Okay, so let's get to one last one. This talks a lot. There's a lot of stuff in the chat around just schools and how stressful school environments have become, and what schools can be doing to prevent self-harm. One other thing that I want to bring up is we all have these like sitting right next to us, as do our young people, and there's there's a lot of wonderful things about technology, and there's a lot of really not good things about technology, especially with younger people. And just groups that can be found in social media outlets or just online that can actually serve to, again, just like perpetuate and reinforce some of these behaviors. But in terms of school and prevention opportunities in school.
So one thing I'll say about the schools is, again, validating where the kids are coming from. I'm thinking about being that age several decades ago and how different it is now. There's no way to turn off school at this point. Kids are in constant contact with their peers through technology. It's very hard for them to separate from their social lives, even while being at home. One of the things we can do is know who the teachers are and have connections with the school therapist. And really have that open dialogue, that we're not relying on body checks or other things with the kids, making sure that they feel comfortable reaching out to parents and consulting to us. If the kid feels like, parents are going to plow ahead and problem solve without validating first, it actually makes it a lot harder for kids to open up and share this information with parents. So again, that's where the curious and non-judgmental stance can be really helpful in addressing school difficulties, by giving kids the understanding that they can come to you, you can validate and understand, versus jumping in before understanding what's happening.
Yeah. I would just add that in terms of education in our education system, I would love for a day to come where as much funding was put into social emotional learning at school as is put into, I don't know, algebra or geometry. I just think that social emotional learning, emotion regulation skills, these are skills. They can be taught, and like any other skill, when you practice them, you get better, you get more confident in using these skills. And if more time was dedicated in school to teaching these skills from kindergarten through 12th grade, I think that our young people would be better equipped to deal with the stressors that confront them in day-to-day life and being a young person in 2023. So
Absolutely.
with that said, we finished 2 minutes early. What we will try to do is we'll go through the chat and take some screen grabs as well. So maybe we can even via email get out some answers to some of the questions that we didn't get to, because there's so many good ones in here. I feel like we could have talked for 3 hours about this, especially with all the great questions in the chat. So thank you all so much for attending. Thanks for being so active in the chat and being such great participants. It really makes these discussions more powerful and come to life. And thank you so much, Dr. Maurrasse, for the presentation and for the education.
Thank you so much for having me.
Okay. Have a wonderful afternoon, evening, everybody.